Let's talk about the drugs which are used in coagulation disorders. So we have drugs which are used in clotting disorders, which are anti-clotting drugs as well as drugs that facilitate clotting. So now let's talk about anti-clotting drugs. So we have, first of all, we have three classes: anticoagulants, thrombolytics, and antiplatelet drugs. And for the drugs that facilitate clotting, we have vitamin K, vitamin K1, and antiplasmin drugs. So now let's talk about anti-clotting drugs and specifically anticoagulants. So please remember heparin and warfarin first of all, and then remember direct thrombin inhibitors and direct factor 10A inhibitors. So we have factor 2 and 10A inhibitors in heparin and warfarin in the anticoagulants. Now let's talk about thrombolytics. In the thrombolytics, we have tissue plasminogens and activating factor derivatives, and also streptokinase. Then we have antiplatelet drugs. For the antiplatelet drugs, please remember aspirin, and also remember glycoprotein 2B or 3A inhibitor, and then remember adenosine inhibitor, and then remember ADP inhibitor. So please remember ADP inhibitor, clopidogrel, and for the PDE or adenosine uptake inhibitor, okay, which is phosphodiesterase or adenosine uptake inhibitor. For the anticoagulants inhibit the formation of fibrin clots. Three major types are available: heparin and related products, which may be used parenterally; direct thrombin and factor 10 inhibitors, which are used parenterally as well as orally; and then we have the warfarin, which is only given orally. These are active coumarin derivatives. Comparative properties are shown. Now let's talk about heparin. Heparin is a large sulfated polysaccharide polymer, so it is basically a protein. It is obtained from animal sources, so it can be allergic. Each batch has molecules of varying size with an average molecular weight of 15,000 to 20,000. Heparin is highly acidic. It can be neutralized by protamine, and heparin is given through IV or SC, which is intravenously or subcutaneously, and the risk of hematoma is associated with intramuscular injection. So never give heparin intramuscularly. Then we have low molecular weight fractions of heparin. These are fractionated heparin. Example is enoxaparin. They have molecular weight between 2,000 and 6,000. Low molecular weight heparin have greater bioavailability because they are small and they have a longer duration of action as compared to high molecular weight or unfractionated heparin. So doses can be given less frequently, once or twice a day. They're given subcutaneously. Then we have fondaparinux, which is synthetic drug that has the biologically active pentasaccharides which are present in unfractionated as well as fractionated heparins. It is administered subcutaneously once daily. Now let's talk about the mechanism and effects. So unfractionated heparin is an indirect thrombin inhibitor. Unfractionated heparin will bind to endogenous 83, which is antithrombin 3, through a pentasaccharide sequence. So what is antithrombin 3? Antithrombin 3 is an endogenous anti-clotting protein which will irreversibly inactivate thrombin and factor 10A. Its enzymatic action is markedly accelerated with the help of heparin. So then we have UFH83 complex formed, or unfractionated heparin antithrombin 3 complex has been formed. So heparin has now bound to an anti-clotting factor, and it will irreversibly inactivate the thrombin and 10A factors. In the presence of heparin, antithrombin 3 will proteolyze thrombin and factor 10A approximately 1,000-fold faster than its absence. Because it acts on preformed blood components, heparin will provide anticoagulation immediately after administration. The action of heparin is monitored with the help of APTT. APTT is only given in the case of heparin. This is basically a test which is called activated partial thromboplastin time laboratory test. Then we have low molecular weight heparin. Examples are EDT, which are enoxaparin, dalteparin, and tinzaparin. And we also have something synthetic, which is fondaparinux. Like unfractionated heparin, it will bind with antithrombin 3. These complexes have the same inhibitory effect on factor 10A as the unfractionated heparin antithrombin 3 complex. However, the short chain low molecular weight heparin antithrombin 3 and fondaparinux antithrombin 3 complexes will provide a more selective action because they fail to affect thrombin, so they are more selective. The activated partial thromboplastin test does not reliably measure the anticoagulant effect of the low molecular weight heparin and fondaparinux. This is a potential problem, especially in patients with renal failure, because it does not reliably measure the anticoagulant effect of low molecular weight heparin. Especially, this is very difficult in renal failure patients in whom clearance may be decreased. Now let's talk about the clinical uses of heparin. Because it has rapid effects, so it is given when anticoagulants are needed immediately, especially when starting therapy. So common uses include DVT, which is disseminated vascular thrombosis, also embolism, pulmonary embolism, and myocardial infarction acute. Heparin is used in combination with thrombolytics when it is used for revascularization, and heparin is used with glycoprotein 2B or 3A when we need it for stenting or during angioplasty or stenting, because it does not cross the placental barrier, so it is very safe during pregnancy. And low molecular weight heparin and fondaparinux have the same mechanism of action and clinical applications. Now let's talk about the toxicity and reversal of heparin. Increased bleeding is the most common adverse effect of heparin and related molecules. Bleeding may result in hemorrhagic stroke. Protamine can lessen the risk of serious bleeding, and then that can result from excessive unfractionated heparin or high molecular weight heparin. Protamine only partially reverses the effect of low molecular weight heparin, but it does not affect the action of fondaparinux. UFH causes moderate transient thrombocytopenia in many patients. So what is the contraindication? So we cannot give heparin or UFH in people who have thrombocytopenia, which means that they have less a number of platelets. And it can also cause thrombosis in patients. So we have a term which is called heparin-induced thrombocytopenia, which is in which a small number of patients who produce an antibody that binds to a complement that binds to a complex of heparin and platelet factor 4. Low molecular weight heparin and fondaparinux are less likely to cause this immune-mediated thrombocytopenia. Prolonged use of unfractionated heparin is associated with osteoporosis. So it can cause osteoporosis, it can cause bleeding, and it can also cause embolism and also thrombocytopenia. Now let's talk about direct thrombin effects. And when we talk about the toxicity of heparin, please remember all H's. It can cause hemorrhage. Due to excessive bleeding, it can cause hemorrhage, HIT, which is heparin-induced thrombocytopenia, and it can also cause hemorrhagic stroke. Okay, now let's talk about direct thrombin inhibitors. So for that, please remember lepidolin, all DEANs. Okay, so the most important one is dabigatran, which often comes in MCQs, and then we have argatroban, dabigatran, argatroban, and lepidolin, desirudin, and bivalirudin also. Lepidolin, desirudin, and bivalirudin, and then we have argatroban and dabigatran. So direct thrombin inhibitors are based on proteins which are made with the help of Hydudu medicinalis, which is the leech. So lepidolin is no longer available. It is a recombinant form of leech protein hydudin, while desirudin and bivalirudin are modified forms of hydudin. Then we have argatroban. Argatroban is a small molecule with a short half-life, small and short. Okay, and then we have dabigatran. It is the only orally given active direct thrombin inhibitor. Now let's talk about the mechanism and effects of direct thrombin inhibitors: dabigatran, argatroban, desirudin, bivalirudin, lepidolin. The protein analogs of lepidolin will bind simultaneously to the active site of thrombin and to thrombin substrates. So the protein analogs of lepidolin will bind to the active site of thrombin. Argatroban will bind solely to the thrombin active site. Solely to the thrombin active site, argatroban will bind. Unlike the heparin, these drugs will inhibit both soluble thrombin and the thrombin enmeshed within the developing clots, which does not happen in case of heparin. Bivalirudin will inhibit the activation of platelets. Then we have clinical uses. So parenterally given thrombin inhibitors are used as alternatives to heparin, primarily in patients with heparin-induced thrombocytopenia. So in patients with HIT, we can also give direct thrombin inhibitors. Bivalirudin is also used in combination with the aspirin during PUBS, which is percutaneous coronary angioplasty. In percutaneous coronary angioplasty, we're going to specifically give bivalirudin. And okay. Like unfractionated heparin, the action of these drugs can be monitored with the help of APTT test. Advantages of oral direct thrombin inhibitors will include predictable pharmacokinetics, which allows for fixed dosing as well as a predictable immediate anticoagulant response. It is very rapid and it has a very predictable mode of action. It makes routine monitoring or overlapping with other anticoagulants necessary. In addition, these drugs do not interact with the P450 interacting drugs. Dabigatran, which is used by mouth, which is the only drug which is thrombin inhibitor which is used by mouth. It is approved for most of the indications of oral anticoagulation, including the prevention of stroke and systemic embolism in non-valvular atrial fibrillation, prophylaxis of venous thromboembolism following hip or knee replacement surgery, and the reduction of recurrent VTE. So we are going to use dabigatran in VTE, which is basically venous thromboembolism, and which is acquired after hip surgery or after knee surgery. Okay. And also, we can also give this in systemic embolism and also in non-valvular atrial fibrillation. So we have two types of atrial fibrillation, valvular and non-valvular. So we're going to give dabigatran in non-valvular atrial fibrillation and also in venous thromboembolism. Now let's talk about the toxicity of using direct thrombin inhibitors. Like other anticoagulants, the direct thrombin inhibitors will cause bleeding. So we have adarucizumab, which is a humanized FAB fragment, which is monoclonal antibody FAB fragment that binds to the dabigatran and reverses anticoagulant effect. So for reversible, we are going to use adarucizumab, and for toxicity, please remember bleeding. Then we have direct oral factor 10A inhibitors. So we have talked about the factor 2 inhibitors. Now let's talk about the factor 10A inhibitors. So now let's talk about their pharmacokinetics. Oral 10A inhibitors, including the small molecules of, so we have all bans here: rivaroxaban, apixaban, and edoxaban, and also betrixaban. Beer, please remember beer for this, or beer. So we have rivaroxaban, apixaban, edoxaban, and betrixaban. So you do remember Betrix, right? Okay, they have a rapid onset of action and shorter half-life, and as compared to warfarin. These drugs are given as fixed oral doses and they do not require monitoring. They undergo cytochrome P450 dependent and cytochrome P450 independent elimination. So in the case of direct thrombin inhibitors, they are not going to affect the cytochrome P450 system. But in the case of direct oral 10A inhibitors, they are going to undergo cytochrome P450 dependent and independent elimination. Now let's talk about their mechanism and effects. So factor 10A, these small molecules will directly bind to and inhibit both free factor 10A and factor 10A bound in the clotting complex. They will inhibit factor 10A. Clinical use of rivaroxaban. Rivaroxaban is going to be used in venous thromboembolism after hip or knee surgery. For that, we can also use dabigatran in case of factor 2 inhibition. But in case of factor 10A inhibition, we are going to use rivaroxaban after hip or knee surgery and for prevention of stroke in patients with atrial fibrillation without valvular heart disease. So we have atrial fibrillation, but we do not have valvular heart disease. Then we are going to look up into a river and then we are going to give them rivaroxaban. Okay. Then we have apixaban, which is used for the prevention of embolic stroke in patients with non-valvular atrial fibrillation. So for non-valvular atrial fibrillation, please remember apixaban, and also remember dabigatran. Then let's talk about the clinical. We have talked about the clinical uses, VTE, and prevention of stroke. Yeah. Now let's talk about the toxicity of giving 10A inhibitors. So like other anticoagulants, the factor 10A inhibitors can cause bleeding. Andexanet alpha is a modified non-covalent inactive form of human factor 10A developed for reversal effect of 10A inhibitors. So what are we going to give to inhibit the 10A inhibitors? We are going to give Andexanet alpha for 10A inhibitor. And for factor 2 inhibitor, we are going to give what? Something that starts with an I, idarucizumab. And then for factor 10 inhibition, we are going to give andexanet alpha. Now let's talk about warfarin and other coumarin anticoagulants. Warfarin and other coumarin anticoagulants, they are small liver-soluble molecules that are readily absorbed after oral administration. It is highly bound to plasma protein, more than 99%, and its elimination depends upon metabolism by cytochrome P450 enzymes. Mechanism and effects. Warfarin will interfere with the normal post-translational modification of the clotting factors in the liver, and it is a process that depends on the adequate supply of reduced vitamin K. This drug will inhibit vitamin K epoxide reductase. So warfarin will inhibit VCOR, this is vitamin K dependent epoxide reductase, which will normally convert vitamin K epoxide to reduced vitamin K. So it will inhibit VCOR, and convert vitamin K epoxide into reduced vitamin K. The vitamin K dependent factors will include thrombin and factor 2, 7, 9, and 10, and the anticoagulant protein C and protein S. Vitamin K dependent factors, they are important SCQ, so we are going to write factor 2, 7, 9, 10 as well as protein C and protein S. Because the clotting factors have half-lives of 8 to 60 hours in the plasma, the anticoagulant effects is observed only after sufficient time as has passed for elimination of the normal preformed factors. The action of warfarin can be reversed with the help of vitamin K, but recovery will require the synthesis of new normal clotting factors and is therefore slow, which means that it requires 6 to 24 hours. More rapid reversal can be achieved by transfusion with fresh or frozen plasma that contains normal clotting factors or prothrombin complex concentrate, or PCC. This contains vitamin K dependent factors only. The effect of warfarin is monitored with the help of prothrombin time test. So what is the clinical use of warfarin? It is given for all the conditions that heparin is given for. So it is given in DVT and in acute MI and also in embolism or pulmonary embolism, but it is never ever given in pregnant women. Please remember that. So now let's talk about the toxicity of warfarin. Bleeding is the most common adverse effect of giving warfarin. Early in therapy, a period of hypercoagulability with subsequent dermal vascular necrosis can occur. This is due to the deficiency of protein C and endogenous vitamin K, an anticoagulant with a short half-life. Warfarin can cause bone defects and hemorrhage in the developing fetus, and it is contraindicated in pregnancy. So first of all, when they ask you about toxicity, tell them why not to give warfarin in pregnancy. Because it can cause bone defects and it can also cause hemorrhage in the developing fetus. And what else can it cause? It can also cause hypercoagulability because of the absence of the protein C. Because warfarin has a narrow therapeutic window, it is involved in drug interactions. Cytochrome P450 inducing drugs. It is involved in drug interactions. Okay, so we have, for example, carbamazepine, phenytoin, rifampin, and barbiturates. PBCR is the mnemonic for this. Carbamazepine, phenytoin, rifampin, and barbiturates. This will increase the clearance of warfarin and reduce the anticoagulant effect of a given dose. Cytochrome P450 inhibitors, for example, cimetidine and SSRIs and amidrone, will reduce the clearance. So cytochrome P450 inducing drugs, they are going to reduce the anticoagulant effect or reduce the clearance, and they are going to increase the clearance. So cytochrome P450 inducing drugs are going to increase the warfarin clearance. These include rifampin, phenytoin, carbamazepine, and barbiturates. Barbiturates is given in manic disorders. Phenytoin is also given in case of manic syndrome. Carbamazepine is given for diabetes insipidus, and rifampin is given for TB. Okay, so these are going to increase the clearance of warfarin. And cytochrome P450 inhibitors include cimetidine, amidrone, and SSRIs. They will reduce clearance and they will increase the anticoagulant effect. Genetic variability in cytochrome P450, 2C9, and VCOR, vitamin K, epoxide reductase, will affect the responses to warfarin. Algorithms to determine the initial warfarin dose based on cytochrome P450, 2C9, and VCOR, age, body size, and concomitant medications are being tested.